Thank you, Miguel. So this is the controversy point. Is acromioplasty dead? So thank you to bosses, Mariana and Shalif, and thanks our chairman, both of Miguel and Ivan. Ivan just arrived this morning, and thanks for the faculties. This is the few minutes ago, and last night, very warm welcome. Smithfield team and Smithfield Angels. So, do you agree? Is it dead? Is it dead? Dead? How many of you? So, yeah. So we discussed it about the details in literature. So that was proposed long time, 1972 by Dr. Charles Neer, acromioplasty. So you look at the anatomy. This is the acromion. And the rotator cuff CA ligament is attached. I mean, when you move the shoulder, it's always moving together. So it's always attached there, right? So it's to have very good proximities between the shoulder and the acromion. So these are the signs proposed in literature. So I think if you have this kind of patient, you need to make sure that is there any signs of impingement, especially the subacromial crepitation. So for me, if the patient have crepitation or grinding like the knee joint, you should thinking about something impinged on the top. So, and this is always missed. Yeah, sometimes you skip to the MRI, you skip to see the X-ray. In AP, you can see the sclerosis or sourcil sign in eyebrow in French, or acromion spur if you tilt 30 degrees, and sometimes you see the spur at the tuberosity. So there's supposed to be the impingement side, okay? And the outlet view, supraspinal out, is not a good X-ray because many times you can miss it because the acromion, the AC joint and the clavicle always block your view. So this is from the literature proof that it's not a good view to detect the acromion spur, right? Like this patient have the sharp acromion spur, but you cannot see it from the outlet view. So current standard debate about routine use of acromioplasty. So many literature Cochrane review say that it's not necessary to do it routinely. So many literature, also this one, no benefit of routine acromioplasty. So I agree with you, Miguel. And current literature last year in HSM, they found that if you have type 3 acromion spur, lower talent if you decompress the acromion, okay? But in time 1, 2, there's no difference, okay? So the study from Chuhan-O, they make the study between the Western, North American, and East Asian. We found that our morphology is not the same. So Asian tend to have more, okay? Critical shoulder angle is longer and more overhang comparing to the North American. So this is our study. We do the X-ray and also CT scan. We found that there are 5 types of the acromion. So in this type, we call Atlas spur. You have huge spur, you have sharp clew spur, and you have this irregular spur. This kind of spur associated with the tear. Okay, and we also perform the CT scan, and we prove that this this Atlas spur should be decompressed. And also this is a cassette tilt view from our literature. We can measure the size of the spur. Mostly the X-ray from the caudal tilt view, the spur is bigger than normal because it's the shadow view, right? So MRI is not a good tool to detect the spur, okay, because it's not sensitive enough. So don't rely on MRI if you are thinking about the spur. So in conclusion, if you have this kind of spur, huge spur, or Q spur or irregular spur, so this kind of spur you should decompress. So individualized acromioplasty, not routinely. So the patient have the impingement side, especially if you have the acromion crepitation. So thinking about that, and acromion at least. And if you have bursal side tear, thinking about that. Once you get in the joint and you see the abrasion of the cup or you see the bursal side tear, thinking about the wear and tear process. Yeah. So acromioplasty, so the trick is that when you get in, you always see this abrasion. Okay, once you release this abrasion, you can see the spur. Okay, so after you take this identify the spur, try to save the CA ligament. Okay, you see that you identify the spur and also the AC joint. Okay, save this CA ligament. You see this one, you should not cut it. You save it and then you clean. You see this one, the spur is have like a keel or hook shot type. So the way you cut it, you should identify the distal clavicle and draw the line from distal clavicle. So this is before and this after. You should see the flat acromion parallel to the distal clavicle. So this is a sister of my friend. I treat her conservatively for 2 years. You look at this, she have the suicide sign, she have heel spur. Okay, so I do 5 steroid injection for her. She said, "Doctor, please do something for me. MI look okay, but every time I do internal rotation, there's so much pain." So this is after surgery, just 4 weeks. She's very happy, the pain is gone. So that proves that this pathologic spur, the atlas spur, you should take it out. Okay, this patient, she is my auntie, right? She has a big spur. If it's your mother, will you step this spur? I don't think so. Yeah, so after we get in, we found that she has the acromion spur, and after the surgery, you see that when you do internal rotation, the acromion is very close to your rotator cuff. Imagine if you have big spur here, that can damage your rotator cuff. Okay, so this is another patient, the same bursal site here. So this patient have poor cuff qualities. I need to put ligenitan because it's really bad tissue, right? So after surgery, the patient happy and have good outcome. This is another failed rotator cuff because the first surgeon did not take this out. Yeah, so he has retear, and we get in, we found that his big spur. We take it out, we repair it, and the patient happy. So be careful, don't make it too much. You can break the acromion. This is one of the patient referred to me. So in conclusion, acromioplasty, routinely, I don't agree. But you should customize. You look at the clinical side is that subacromion crepitations. Don't miss the spur like suicide spur or the GT spur. Pathologic spur, thinking about heel, keel, and also the irregular spur. If there's CA abrasion and bursal site tear, you should take it out. Okay? Thank you so much. And this is our meeting in Thailand in stability. Thank you.